RehabMyPatient.com has had a massive update. 1,000 strength and conditioning exercises have been added to the library for you to prescribe to your patients. Pictures, videos, fully customizable text, deliverable by email and WhatsApp. What is not to love? Go to rehabmypatient.com/physio matters for a 3-month free trial on us. Hello, everybody. Welcome back to Chewing It Over. It's Jim here from the team, and I'm absolutely delighted to be joined by Belinda Beck. So, Belinda, I just wanted to start with the first question, really, which is, what is osteoporosis?
Well, the definition has changed over the years, but it is essentially a condition of low bone mass and strength that increases your risk of fracture. So it has become very much more a fracture definition rather than specific to bone mass, because we know that you can fracture, have a minimal trauma fracture, even when your bone mass isn't very, very low.
That's really interesting, because I think a lot of people who are listening would definitely say something like, oh, your Z score on a DEXA scan is below a certain number. So we're moving away from that more towards this fracture risk. So that would include things like risk of falling and stuff like that. Is that fair?
Yeah. Sorry, I should probably have elaborated a little. The definition, the sort of clinical and diagnostic definitions are slightly different. So if somebody appears in hospital with a minimal trauma fracture and they've never had a DEXA scan, if they've just sort of tripped down a stair, landed heavily and crushed a vertebrae, that instantly tells you that's minimal trauma, so that qualifies. But if you are wanting to screen for osteoporosis and you have a DEXA scan, then the definition is a T score of -2.5. That's 2.5 standard deviations from what they call the young normal, and that is somebody who's the same sex and race as you, age 20. So you're not being compared to, the Z score is actually comparing to your own age, but osteoporosis is defined based on what the average for you would have been age 20. And this is just sort of to give an indication of what you may have lost across life, because we know that if you have a T score of -2.5, you're at greatly increased risk of fracture. But what I was alluding to before is, if you think of all the BMDs of everybody with, say, over the age of 50, it's a bell curve. And so there's some with very high bone mass and some with very low. Those with very low, osteoporosis on a DEXA scan, because they're -2.5 and very high risk of fracture. But the vast majority of people actually fall in that osteopenic zone, which is -1 to -2.5. And just by virtue of the fact that there are many, many more people in that zone, more people actually fracture with osteopenia. So it's a statistical sort of a situation. And that's why I say it's really important, if you do have osteopenia, you are to know that you are still at risk of these minimal trauma fractures. You don't have to get to, it's not a magic number. It's more for doctors to know when they should start prescribing the bone medications.
Yeah. Okay. Yeah, it's brilliant. That's thanks for that clarification. That's, really interesting. So tell us a little bit about you. I mean, I've known about your work for a while. I'm not certain whether a lot of people do, or my belief is not enough people do, but there's that. But tell us a bit about you and how you've ended up at where you're at the moment.
Well, I guess I'm a bonehead through and through. I love bone tissue. I find it eternally fascinating. It's been what I have studied my whole career. I started really mainly studying bone stress injuries because I was a runner myself and constantly suffered from this. And so my investigation in trying to figure out why they happen led me down the path of looking at mechanical loading of bone. I began my career doing animal research and then moved into clinical trials in my postdoc, and then pretty much have worked in the field trying to figure out what is the absolute best exercise intervention to prevent people from having these osteoporotic fractures. And for years and years and years, of course, we struggled with this this catch-22 of people knowing that bone responds to high strain the most. If low strains, it doesn't even get out of bed in the morning. But if you put a very high strain on somebody with osteoporosis, then we all thought, well, you can't do that because you'll risk fracture. But the reality was nobody had actually tested it, and so we didn't know. And so that's where the last 10 years, or maybe 8 to 10 years of my research career have been focused on actually testing this heavy lifting and impact in this demographic and finding out whether we can grow bone and whether it's safe.
Mm. And it does seem counterintuitive, doesn't it? You mentioned about before, if you have an increase in load, a low trauma fracture, for example, then seems counterintuitive to actually apply quite a heavy load. But as we've seen from your research, or your team's research specifically, that doesn't happen even in. I mean, I'd be interested to know if you were surprised at how few adverse outcomes you had. But from my opinion, I was definitely surprised that you didn't get almost any at all.
Yeah, I can't imagine there were too many people that weren't surprised, and it's because we were all too scared to do it for years because we didn't want to hurt anybody, and including me. So I'd have to say we were actually watching through our fingers when we were doing the Lift More trial, because we were so keen to not hurt anybody. But I had 3 physiotherapists on the trial. I'm not a physiotherapist myself. I'm an exercise scientist and physiologist. And the trick was, although we did recruit people with low to very low bone mass, it was specifically for people with, at risk of fracture, because we wanted to make sure that this is what we were testing. We watched them like hawks. So the trick was supervision really making sure their technique was perfect and that the progressions were appropriate. So in the end, it turned out we thought we were going to need, a month worth of introducing and teaching and so on. After a while, we started thinking, this is ridiculous. They learn these quite quickly and we can start loading them up. You don't go from 0 to 100 overnight, but certainly we were able to load much more quickly and much more heavy than I was expecting. And when the first scans came back in that Lift More trial, it was one of those I remember where I was moments. It was I can't believe this person has just grown 9% of bone. That just doesn't happen with exercise. Of course, not everybody grows that much, but that was our very first participant in the Lift More trial, and we were just over the moon. The rest is sort of history.
Yeah, I think that combination of safety and effectiveness was, or is, just massively surprising. I suppose from your point of view, following on from the Lift More trial, and you have to forgive me, I don't remember exactly when it was published. I'm sure you remember where you were. I'm sure you remember exactly when it was. Do you feel like it's changing the needle with people loading more? Or, obviously one of the reasons I wanted to get you on something like this is I want to try and push that needle further. I teach in rheumatology, and that encompasses some osteoporosis, and people, in my opinion, certainly physios, still seem way too scared of loading their patients. But have you seen any change moving forwards?
I have. It's I use the expression, it's like cold molasses. It just is very, very slow process, because given that most people are managed, or most people are diagnosed and managed with osteoporosis through their GPs, and GPs are risk averse. Understandably, they don't get very much exercise training. In fact, they get almost none in medical school because they've got so many other things that they have to learn. So I guess they're also aware that for years they've been trying to get their patients to do exercise for diabetes and heart disease and so on, and adherence uptake is reasonably low. So they're quite negative about it, as even though they know that it probably does work, they are a little bit hesitant to prescribe it over the medications because they think, well, at least they'll take the medications. Turns out people don't like the medications either. So it's a little bit of a race to the bottom, if you like, in terms of getting people to do something. I have been, since we actually developed the program into a product, which is called Oniro, and it has been, I've been sort of desperately trying to distribute it through physios and exercise physiologists. Certainly the profile has increased and it snowballs somewhat. So physios will see another physio practice delivering Oniro and they'll go, what? Are you hurting anybody? No, getting these incredible results. And it sort of spreads that way. I don't market this product per se. It just, it grows organically. But I do go to conferences and I talk to people like you, just trying to reduce the fear, if you like, because exercise is really so safe in most situations. And it's not like I'm saying do this program on your own at the gym. It's do this program supervised so you're safe, and really I think the risk is very low.
Yeah, I think from my point of view as well, there's a lot of public messaging, not necessarily from it's the right turn of phrase, reputable sources, but a lot of messaging around if you've got low bone density, not flexing at the spine, for example, is probably the classic one, to try and prevent anterior vertebra wedging, and I think that seems problematic for me to get over, because that's what I find is sort of counterintuitive, isn't it? Where if you theorize you've got low bone density in the vertebrae, and then you load the front portion by flexion, that it stands to reason that it could wedge anteriorly. But as you guys have shown, that's not really the case. What do you think about us how do we counter those sort of narratives, do you think?
Well, to be clear, I don't advocate for deep forward flexion because I still believe that is the case. So our exercises, we very much emphasize a neutral spine. So even if we bend forward, you want that spine posture to not be not a flexion moment, it's an extension moment, if anything. So that's part of the educational process. As I say, it's really all about education and sort of working through that. You're quite right when you say some very reputable groups do still trot out very conservative messages, and I don't want to malign anybody in particular here, but just this month, a very high-profile group just posted an extremely conservative recommendation for exercise for osteoporosis, and it's just terribly disappointing. Not that those exercises are going to cause harm, most likely. They're, because anything is better than just sitting on your butt. But what it does is it gives people the impression that is enough. And so it displaces this opportunity to do effective exercise. And that's the most frustrating thing, giving people the impression that going for a walk or doing some wall push-ups is going to be enough for osteoporosis. It's just not. In fact, telling a very frail person to go for a walk actually increases their risk of fracture, because if they're very doddery, they're going to fall.
Yeah, no, exactly. And yeah, to clarify, I'm not suggesting I get my patients to do Jefferson curls into deep flexion. I was more talking about unloaded bending, and of course, if you do a squat and deadlift and stuff, you get a little bit of flexion at the spine. You can't really avoid it, can you? But I wasn't saying we should do Jefferson curls, but I think, like you say, I've definitely seen even recently, avoiding any forward flexion, which is clearly problematic functionally as much as anything else.
Well, exactly. Think how many times you have to sort of lean forward in your daily life. You're sort of reaching forward to pick your cup of tea off the table. But But the fact of the matter is, when we do teach these exercises, we're always sort of educating people that this isn't just what you do when you're here at the clinic. This is what you do when you're picking up that bag of potting mix at the local store. Don't bend down and lift this huge, heavy thing with a big bent spine. Bend your knees, keep your back straight, and try and if you've got a T-score of -3, you shouldn't be lifting that thing anyway. but it is a different matter doing heavy lifting outside of, a really controlled, supervised exercise. But safe spine position during loading is just a mantra, really.
Yeah, and that's obviously individualized, right? So for some people, they'll be able to lift larger loads than other people because they've either been through your program or they've just exposed themselves to that kind of load. Is that fair to say?
Yeah, for sure. But if somebody comes and they can already, do a 100-kilo deadlift, we're talking about men here. It's very rare to have a woman be able to lift that heavy. If they can already do that, I'd be willing to bet that their bones are pretty good anyway. So we're starting, when we introduce the program, we're talking broomsticks, where it's pretty light. But there are people who come to us with terrible bones because for all manner of reasons, maybe they were dramatically calorie restricting when they were teenagers, and so they developed a very very poor skeleton when they were young, or maybe they've been on high doses of steroids throughout their life for respiratory conditions or other inflammatory conditions, and that does terrible things to your bone. So even though they've been very active, they've come to us with low bone mass. Now, those people probably have pretty good muscle strength, and quite often they have great body awareness. So there's not a huge amount of teaching we have to do with them. On the other hand, you can have Grandma Mabel who comes in at age 80 and she's never lifted anything heavier than, her kettle, which, mind you, when it's full can be quite heavy, but has absolutely no idea of where her body is in space. Plus, she's had that aging effect, that neuromuscular sort of decrement over life. So we're actually teaching her to move before we're even teaching her to lift. And that process can be really life-changing for her in terms of her mobility around her house.
Yeah, for sure. So I suppose to get on to the next section of what I wanted to ask really would be if there are physios or other healthcare professionals listening who are thinking, oh, actually, maybe I do underload my osteoporosis patients. What would be your sort of first tips to them to start loading people a little bit heavier?
Well, learn about what you're doing first. Don't just go in guns blazing and going, I'm just gonna do this. We did publish the Lift More program, and we're scientists, we publish what we do. So it is in the public domain, but the reason why we developed it into a program and licensed it was so that people knew how to apply it safely and with high fidelity. Because if you just take a couple of the exercises and modify it for individuals, that might be perfectly fine. It might be appropriate for that person, but then it's no longer evidence-based. So, I think becoming educated about it is definitely the first step. And although, I don't want this to be a big ad or marketing campaign for Neuro, that's really obviously where I think people should be going.
Yeah, while we're there, where would they find more information about that?
Oh, best thing is just type in Neuro Academy into Google, and it'll pop up. It's got a bunch of information about that on there, or they're welcome to just email me.
Perfect.
Look at the Bone Clinic, which is where we deliver it. It's my research facility. It is a clinic, but it's primarily a research facility, and got more information there. Brilliant. So you are, I'm delighted to say you are speaking for us at Therapy Live and I think the title is Lift More and Beyond. I think that's what I'm right in remembering. That's right.
Yeah, really excited about that. 24th of June. I will link to the resources you've just mentioned, Nero, in the show notes of this as well, and pop your social media handles on there as well, if that's okay with you.
Yeah, sure.
Perfect. Brilliant. So thank you very much for spending the last 20 minutes or so with me talking about osteoporosis. Really looking forward to Therapy Live and learning more about osteoporosis as well. It's absolutely brilliant.
My pleasure. Looking forward to it.
Here at Physio Matters, we think physio matters. Join as a premium member now and access over 500 videos, get free tickets to shows and upgrades included. Access at home, work or on a unicycle to take your knowledge to the moon. Physio-matters.com, more content than you can fit into a gym.